Hello, everyone, and welcome to day 2 of the 2023 PI conference. We will get started in just a moment. My name is Zach Moore, and I will be your moderator for today's session, Primary versus Secondary Immunodeficiency. I'm very excited to welcome Dr. Foulion, who will be guiding us through today's topic. There will be time for questions at the end of the presentation, so please submit any questions you may have to the presenter in the Q&A section of the platform. A bit about Dr. Foulion. Dr. Foulion is a professor of pediatrics at CUMC, is the clinical director of pediatric allergy, immunology, rheumatology at Columbia University Irving Medical Center, and program director of the Allergy and Immunology Fellowship at New York Presbyterian Hospital. He has served as the division chief of allergy and immunology at Sidra Medicine, professor of pediatrics at Northwestern University Feinberg School of Medicine, and director of primary immunodeficiency clinical services and the Jeffrey Modell Diagnostic and Research Center for Primary Immunodeficiencies at Ann and Robert H. Lurie Children's Hospital of Chicago. Dr. Foulion earned his MD from the American University of Beirut and completed pediatric residency at Duke University and allergy and immunology fellowship at Children's Hospital, Harvard Medical School. His research interest is the pathogenesis and treatment of primary immunodeficiency diseases. He completed a 6-year term as a member of the board of directors of the American Board of Allergy and Immunology. He is a fellow of the American Academy of Allergy, Asthma, and Immunology, where he served as chair of the Primary Immunodeficiency Committee, an inaugural fellow of the Clinical Immunology Society, where he served as chair of the CME Committee, member of the European Society for Immunodeficiencies, and Society for Pediatric Research. He serves on the Medical Advisory Committee for the Immune Deficiency Foundation. So thank you so much for everything and for joining us, Dr. Foulion. I'll turn it over to you.
Thank you very much for the kind introduction, and thank you to the organizers for inviting me to speak on this interesting topic. I'll go ahead and share my screen. Okay, welcome everyone. So I was asked to speak on differences between primary and secondary immune deficiencies. And in many ways, I think of them as just different causes for immune deficiencies. And we'll show you what I'm talking about. So just in terms of disclosures, I have served as a consultant to several pharma companies, Takeda, Horizon, and Farming, but I won't be discussing any specific products here today, so there should be no conflicts. The focus is the immune system and the immune deficiency and the effect of it on our health. The immune response is there to protect us from invading pathogens. The immune system can clear extracellular pathogens and their toxins. It can kill intracellular pathogens. It kills virally infected cells. It does perform surveillance for and killing of some malignant cells. But it can also result in allergic or autoimmune disease and inflammatory diseases as well. You can think of the immune system in a variety of ways. One way is to think of the innate versus the adaptive immune system. The innate immune system involves many factors, including the skin and mucous membrane, which serves as a barrier, the cilia and mucus that clear the respiratory tract from infectious organisms. We have cells called phagocytes. They take up phagos sort of eat, so they eat pathogens. These are monocytes, macrophages, and neutrophils. The innate immune system recognizes pathogens through what are called pattern recognition receptors. So through these, they recognize a whole class of pathogen. There's no memory. And they can't identify one pathogen from another. They just recognize that it's from this class of pathogen. This recognition is important. It starts an inflammatory response that's necessary for the adaptive immune response that most of us are more familiar with, which is to make antibodies and for T cells to help fight infection. So this first recognition is very important to get our more effective immune system, if you like, active and activated. There are also proteins that play a role, complement proteins. They get their name because they complement the function of antibodies, but they can be activated directly without antibody in the alternative pathway and either kill bacteria or help the phagocytes take up the bacteria. The blood also releases other acute phase reactants, and all these help sort of either kill or facilitate the uptake of the pathogens by phagocytic cells. Now, the adaptive immune system is a lot more specific. You can recognize a particular type of bacteria. You can recognize, you may be aware of the different serotypes of pneumococcal bacteria. Well, the adaptive immune system will recognize one serotype of pneumococcal bacteria from the other. Because we like to have a large variety of recognition, we have very few cells that will recognize a particular pathogen. And so those cells, when they're needed, they have to divide, so there are enough of them to kill. And so there's a delay in the activation of the adaptive immune system of 5 to 7 days before it's very effective. But after that, after the initial response, we have a memory response that on second exposure will respond much more quickly. And this can be divided, that adaptive immune system can be divided into antibodies that are made by B cells, and these can clear extracellular pathogens and their toxins, or T cells, which can help the B cells make antibodies, or actually do, it's not just they do help B cells make antibodies. They help the phagocytes clear some of the pathogens they've taken up, or they will kill viral infected cells as well as malignant cells. So in a very sort of schematic cartoon, looking at the different aspects of the immune system, we have B cells that make antibody. An antibody on its own or with complement can kill bacteria or help them being taken up by phagocytes. These are neutrophils, polymorphonucleocytes, and monocytes, macrophages. But on their own, the B cells will only make IgM antibodies. They need T cell help to switch and make other antibodies. So CD4 T cells will help B cells make antibody. And some pathogens, even though they've been taken up by a macrophage, can't be cleared by the macrophage until they get help from a CD4 T cell. And then the CD8 T cells are the ones that kill virally infected cells and clear viruses, and will kill malignant T cells malignant cells as well. So primary immune deficiencies result from single gene defects. We know about 485 different diseases or gene defects, but this number is growing all the time. At least 20 or more every year are added to the list. These defects affect one or more components of either the innate or the adaptive immune system. And as a result, there's a susceptibility to recurrent infections, autoimmunity, inflammation, or malignancy, or allergy too. More recently, we've recognized genetic defects of the immune system that lead not only to immune deficiency, but immune dysregulation, autoinflammation. So there's a new term out there called inborn errors of immunity that encompasses the primary immune deficiencies, but other immune defects that sometimes have immune deficiency, but sometimes have other factors such as immune dysregulation. And sometimes it's only autoinflammation, like the periodic fevers. But they're all considered defects of immunity. And what defines primary is the fact that it's an underlying genetic defect that's inherited that then results in the disease. Secondary immune deficiencies, on the other hand, they are immune deficiency diseases that may resemble primary immune deficiencies to a large extent, but they're caused by a variety of external or internal factors. By external, I mean things like medications, chemotherapy. We're using biologics to treat diseases. Those sort of interfere in some of the immune system pathways. Viral infections, a clear example is HIV that causes a loss of CD4 T cells and causes a severe immune deficiency. And some internal factors, examples are autoantibodies against immune cells or immune factors that lead to an immune deficiency, and I'll show you some examples of those. And there are some conditions where there's protein loss in the GI tract or the kidneys or through the lymph system. And depending on the severity, you may lose immunoglobulin and become hypogamma-globulinic, not because you're not making the antibodies, because you're just losing them too quickly. The International Union of Immunological Societies divided the inborn errors of immunity into 10 groups right now. The first is severe immune deficiencies affecting both the cellular and humoral, so T cells and B cells and antibodies, so combined immune deficiencies, and severe combined immune deficiency falls in that. There are other combined immune deficiencies that have particular features. The predominantly antibody deficiencies, their disease of immune dysregulation, defects in phagocyte number or function, defects of innate immunity, autoinflammation, complement deficiency, bone marrow failure, and phenocopies of inborn errors of immunity. These are conditions that I will show you some examples of that look exactly like other inborn errors of immunity, but they are not caused by an underlying genetic disease or a defect. So what are our tools for evaluation and management of immune deficiencies? And here I'm just going to talk about the evaluation first. A lot of it is laboratory based. Of course, there has to be a history of recurrent infections and a reason to look at the immune system. But when a patient presents with their symptoms that are suggestive of immune deficiency, we look in the blood to see what's the immune system doing. We look at a regular blood count. This can tell us if the lymphocytes are low, if the neutrophils are low, if the patient has an associated anemia or low platelets, thrombocytopenia. Then we look at immunoglobulin levels, and that tells us about the humoral immune system. Is there agammaglobulinemia, hypogammaglobulinemia? Is it selective IgA deficiency? The thing to remember when you're looking at all the age groups is that in the first 6 months of life, IgG in the baby is really coming from the mother. And so even if the baby had a severe immune deficiency, the IgG might be normal if the baby's mother had normal IgG and the baby was born at full term. So it's not always reflecting what the baby's doing in the first 6 months of life. Of course, as many of you probably know, that it's not just the immunoglobulin levels. Can we actually make antibody? And that's really what the immune system needs to do and how it prevents infection. And so we check antibody responses to the vaccines because we know if the patient has had those vaccines. And if they are good antibody levels, it means the patient's able to make antibody, patient's able to make memory responses, and the patient's able to switch from IgM to IgG or IgA or the antibodies that need to be done. So that's a very important test. The CBC tells us about the total lymphocytes, but we have to use a technique called flow cytometry to look at the lymphocyte subsets, phenotyping, tell about the different T cell subsets, CD4, CD8 T cells, B cells. We can look at memory or naive B cells or T cells, and we can look at natural killer cells that also help fight infection, but I'm not discussing them any further in this talk. As I mentioned, we have very few cells of any particular specificity, so the cells need to divide. So there are assays to look and see if the lymphocytes can proliferate. That's also very helpful. And when we have low T cells and we want to find out if patient has severe combined immune deficiency or not. We can look at complement function, both classical and alternative. We can see if the neutrophils can kill bacteria, which is the test for chronic granulomatous disease. We can look at the innate immune system by seeing activation via these pattern recognition receptors, but those tests are not always very specific or effective and don't always identify defects. We can look at cytokine and chemokine levels just to measure ongoing inflammation and see what pathways might be overactive or defective. And ultimately, and we're doing this more and more often, as we do genetic testing, starting with a gene panel for primary immune deficiency to try and identify defects, because many of the defects won't show up on our other classical testing. But if we're very suspicious or there are multiple problems, not just the immune system, we might do a more expanded gene sequencing, like whole exome sequencing or whole genome sequencing. The idea is to identify a gene defect, confirm the diagnosis, and potentially find a specific target for therapy, and not just the general types of treatments we do. So I'm going to start with the example of the severe immunodeficiency, and that's severe combined immune deficiency. And this is a very rare inherited severe immune deficiency, but it's life-threatening. It's sort of a medical emergency for immunologists. Patients will not survive more than 1 to 2 years if they're left untreated. They are usually healthy at birth, and you can't tell a newborn that has severe combined immune deficiency from a healthy newborn. But these patients have no T lymphocytes, or their T cell function is absent, but that's less common. They can die from graft versus host disease from a blood transfusion that's not irradiated. So most hospitals now for young children will irradiate the bloods, and some hospitals do it for everybody. And they are susceptible to all infections, including intracellular organisms, viruses, and even viruses from live attenuated vaccines can cause serious infections in these patients. We diagnose this by the absence of T cells, or if the T cells are there, the mitogen proliferation is less than 10% of control. Now, when a baby is born, a lot of times some cells come from the mother to the baby. All healthy children, their T cells will just get rid of any foreign or like maternal cells. But if you can show that there are maternal cells in the baby, sometimes children with SCID who have no T cells of their own will have T cells that came from the mom. And you will, if you can identify that these are coming from the patient's mother, you can diagnose SCID right away. There are variants of SCID where the T cells are there, but the very restricted specificity, it's called the T cell receptor repertoire, is very limited. And those T cells are very dysregulated, and they cause a bad dermatitis, and they can infiltrate the organs. It's known as Omen syndrome. Those babies are sick at birth and have a bad rash, but they may have normal numbers of T cells. So you'd have to do specific testing to confirm, to figure that out. And of course, genetic testing will confirm that there's a gene defect causing severe combined immune deficiency. Lymphocyte phenotyping helps us because in general, the patients have no T cells. They may or may not have any B cells, and they may or may not have any natural killer cells. And based on that phenotype, you can identify potential gene defects. I'm not going to go through them now. In general, transplantation is stem cell transplantation or bone marrow transplantation is the treatment of choice, but we have some conditions where gene therapy works, like the A-deficient SCID, X-linked SCID, and others are being investigated. But also ADA deficient SCID can be given adenosine deaminase enzyme. So we have a variety of options if we know what the underlying cause is. And that's why it's important to identify the underlying cause. Now, can we have secondary T cell immune deficiencies like the severe inherited severe combined immune deficiency? Certainly chemotherapy can affect T cell numbers as well as function. We use anti-T cell monoclonal antibodies usually before transplantation, particularly solid organ transplantation. So this effect should be transient. Eventually the T cells should come back, but they're of course also treated with immunosuppression medications that suppress the function of T cells so that the T cells do not reject the transplanted tissue. And this treatment is lifelong. So there's a lifelong sort of immune defect, if you want. The goal of treatment is to find the lowest dose to prevent rejection, but not cause a severe T cell immune deficiency. But patients may be susceptible to recurrent infections. Steroids can suppress T cell function. It's usually, if it's long-term and high doses of steroids over a long period of time to do that. A short course for, let's say, an asthma exacerbation doesn't usually cause significant immune deficiency, but somebody was having a fungal infection and gets steroids for some reason, or some viral infection and gets steroids and is not getting specific therapy to the infection, may have an exacerbation of their infection because of the steroids. We mentioned HIV before. It leads to markedly reduced CD4 T cells and with poor function. And of course, the treatment there is not a bone marrow transplant, but to treat the HIV infection, and the CD4 T cells get better and they function better with time. some patients can have autoantibodies against the T cells. That's sometimes hard to identify, but if we are able to, then maybe treating the autoimmune disease then may help recover the T cell function. And I mentioned protein loss in the GI tract for losing immunoglobulin, but that many times is also associated with loss of T cells, especially CD4 T cells. There may be very low T cells because of ongoing losses in the GI tract or sometimes in the lymph. But otherwise, especially if the lymph stays in the person, like lymphangiectasia, you might measure very low T cells in the blood, but they may be elsewhere in the body, and therefore that may not be a severe immune deficiency. Just the testing would be low. The next example I'm going to go over is the predominantly antibody deficiencies. And the classic example is X-linked agammaglobulinemia. This is first immunodeficiency that was described a little over 70 years ago by Dr. Ogden Bruton. His patient had no gamma globulins and suffered from recurrent infections. He gave him plasma transfusions, which reduced the frequency of infection. But as you can imagine, there's a limited amount of IgG in plasma, so it wasn't able to really bump get his IgG level to what would be now considered therapeutic. These patients had no B cells. That was discovered later. And as a result, also have no lymph nodes or tonsils, or very, very, very small ones. And later it was discovered that the genetic defect is in a signaling molecule, a tyrosine kinase, that was named Bruton's tyrosine kinase. And this, because it's X-linked, it mostly affects boys, and you only need one affected gene. If you have that, if you're a boy and you have that, then you have this disease. But there are agammaglobulinemia that can occur in both boys and girls, and males and females, and also results from defects in B cell development. But the gene is not on the X chromosome, and so you have to have both copies of that gene affected, and so it's less common. But those genes are necessary for B cell development. The most common symptomatic immune deficiency is common variable immune deficiency. And from its name, it's common. It's really not common in the sense that it's a very common disease, but amongst the immune deficiencies, it's the most common. Variable is because there are a whole variety of conditions, but they're characterized by having a low IgG and at least one other immunoglobulin being low, usually IgA, but it could be IgM, sometimes both. These patients have a problem making vaccines. In general, we like to make the diagnosis of the patients already over 2 years of age, and all other causes of immune deficiency have sort of been ruled out. The peak onset is usually in the second or third decade of life. In some cases, we've seen initially normal immunoglobulins that were tested for what reason, but when they were diagnosed, we saw that the immunoglobulins were lower. So it seems to evolve over time. Patients may have recurrent signs pulmonary infections. They can develop granulomas in the lung and liver. They can have autoimmune or GI, endocrine and hematologic disorders. And about 10% of the patients don't have a history of infection. If you look at the complications in a group of patients who were analyzed with common variable immune deficiency, about 30% had infections only. Almost another 30% had chronic lung disease, and a third of those had bronchiectasis. Autoimmunity was in about 30%. ITP, immune thrombocytopenic purpura, being the most common of those, but autoimmune hemolytic anemia also. About 15% have GI disease, 10% liver or granulomatous disease, about 8% with lymphoma, 7% with other cancers, and 8% underwent splenectomy because of a large spleen. So there's quite a significant amount of morbidity in these patients. Now, when a group tried to see whether the lung complications are because of poor antibody or is it something else? And as you can see, there are a lot of lung complications in CVID, and some of them are shared with X-linked agammaglobulinemia. But clearly, in the total absence of antibody, while you still had some pulmonary complications, there were a lot more in CVID. So some other factors maybe inflammation, autoimmunity play a role in a lot of these complications. So what about genetic cause? The interesting thing about CVID is once you identify a genetic cause, it becomes its own entity. So if you look at the International Union of Immunological Societies classification, it says CVID, the genetic cause is unknown, but all the genetic defects that cause a CVID phenotype are listed there as independently as, and so there have been a number of gene defects. Initially, the most common was a gene called TACI, found in about 10 to 15% of CVID patients, but they found other individuals related to these patients who had the same variant in the gene, but did not have CVID. And so it's not clear that it's enough to cause CVID. So there may be other factors. Some patients have one copy affected, others have both copies. Seemed that autoimmunity was higher amongst those who had only one copy affected, but it's not, at this point, it's not clear what the genetic cause is, what the effect of the TACI gene defect is on, and whether some other factors are needed to express disease. And I mentioned another antibody deficiency where immunoglobulin levels are normal, but there's poor response to vaccines, and we call that specific antibody deficiency. The immunoglobulin levels are maybe normal or very close to normal, but these patients don't make antibody, particularly to polysaccharide antigens, so the unconjugated pneumococcal vaccine. And the real-life bacteria are unconjugated. So this looks a lot more like the response to the real bacteria. Now, to help children make antibody against pneumococcus, because in the first 2 years of life, the immune system isn't able to make good antibody responses to the polysaccharide vaccines or antigens, they conjugated the vaccine. And that's helped make good antibody responses and prevent serious pneumococcal disease in infancy and early childhood. So when we're looking at children or other individuals who've already had the conjugate vaccine, and we use the unconjugated 23-valent vaccine, to look at the unconjugated response, we look at the 11 serotypes that are not in the childhood vaccine. And we want to see at least 50% good response, a level of 1.3 or higher. For adults, sometimes people say 70%. Certainly, if it's less than 50, it is a problem. So what about secondary B cell and antibody immune deficiencies? And we see probably more of those than maybe T cells. And here medications play a big role. We now have anti-B cell monoclonal antibody therapy that's usually given for severe autoimmune disease to deplete the autoantibody generating B cells, but it also depletes all B cells, so even the B cells that make regular antibody. This should be transient, but depending on the study, up to 40% of patients may not recover their B cells and have agammaglobulinemia, as if they are an agammaglobulinemic primary immune deficiency. But this only happened because we treated them with the antibody. And some will recover their B cells, but they still fail to make normal IgG levels, so they have hypogammaglobulinemia. And if they have the same phenotype as CVID, you could call it CVID, except it's happened after you gave an antibody and not because it's something that was going to happen, that because of an inherited gene defect. But they even make normal immunoglobulin, but don't make good antibody responses, just like the specific antibody deficiency. So what's not clear is why does this happen to some patients and not others? Is there an underlying genetic cause? And if there is one, so could it be that this antibody therapy just unmasked an immune deficiency that was going to happen? We still don't have answers to those questions. But if there was an underlying gene defect that normally doesn't cause an immune deficiency, would be considered primary or secondary? Of course, I think that's semantics. The important point is, if there's a deficiency of antibody, then it's an immune deficiency, and we have to deal with it, especially if the patient's having recurrent infections. Patients can make autoantibodies, not just against red cells and platelets, but against B cells, and as I mentioned earlier, T cells. Again, if there's a genetic predisposition to autoimmunity, in those cases, that we don't always, it's not always that the same autoimmune disease will happen. And then again, is this a primary or secondary? It just happened to be against B cells. Again, not as important as the fact that the cause is autoantibody disease, and you would want to get rid of the autoantibodies, and maybe the B cells will eventually recover, or the normal B cells will eventually recover. And we mentioned earlier, protein loss in the GI tract can be associated with low immunoglobulin levels. Here, the treatment is a problem, because if you give immunoglobulin replacement, whether IV or subcutaneously, it's going to get lost again in the GI tract. So you're just chasing yourself. And you may, if the patient's having some infections, maybe prophylactic antimicrobials, antibiotics, or depending on the infection, maybe a more reasonable approach. In general, most of these patients don't have too many infections, and so it may not be necessary to treat. And so how do we treat antibody deficiency? Whether it's primary or secondary, if we don't make antibodies and we have recurrent infections, then we need to treat the patients with immunoglobulin replacement, giving them antibodies to prevent infection. This can be done intravenously. We start out at a dose of around 500 milligrams per kilogram, but we like to use up everything in the vials that we're using, so we have a range, and we tend to updose. It's a lot of effort goes into making IVIG, and it's expensive, and it's sort of a shame to waste it. The patient benefits from it rather than not using it. But it can also be given subcutaneously under the skin, and it can be done every 1 or 2 weeks. And there are products that can be given in larger quantities, so you can maybe do it every 4 weeks. And this is for patients who cannot produce protective antibody levels from absent B cells, agammaglobulinemia. I didn't mention hyper IgM syndrome, common variable immune deficiency, even hypogammaglobulinemia, or antibody deficiency syndrome, which you could try first with antibiotic prophylaxis. But if they get a lot of viral infections, the antibiotic prophylaxis won't stop that. And so you would want to go ahead to immunoglobulin, or if they are having severe infections that make them come into the hospital, pneumonia or intensive care unit, we clearly want to be aggressive. Would be the same for the secondary immune deficiencies that have no antibodies. And we need to either, unless it's loss, we can replace immunoglobulins by subcutaneously or IV. A nice study from the UK kept on increasing the dose until patients stopped having infections. And they found that there was really no trough level or particular dose that you could identify. It's just that different patients needed different amounts. There was a lot more variability in common variable immune deficiency than in XLA, which makes sense, because XLA, everything you're giving them works well, whereas CVID, they make some antibody that may not, or some immunoglobulin that may not work well. What are the side effects with intravenous? You can get transfusion-like reactions, fever, chills. You can get allergic reactions in totally IgA deficient patients. While it has been demonstrated, though, this is not very common, and most of the products have lower amounts of IgA now than they used to in the past. Sometimes patients get bad headaches and even aseptic meningitis, and slowing the rate of infusion helps. Ibuprofen prophylaxis also tends to help. There have been reports of renal dysfunction and thrombosis, but those are rare. Some patients' neutrophil counts drop transiently. And in the past, there was some transmission of hepatitis C. Luckily, the way IVIG was made, it killed the HIV virus. So even before we knew about HIV, there was no transmission of HIV. But hepatitis C was a little more complicated. But since then, they've changed the way that's produced, and they've changed the antiviral processing steps so that hepatitis C does not get transmitted anymore. And all known viruses right now are get killed in the process of production of IVIG. Subcutaneous has a lot more local side effects, some pain, redness, and swelling at the site of infusion. Some patients can have systemic side effects, but it's not as common as was seen with IVIG. And just to show you with this treatment how with IVIG, we used to like trough levels of 600. Now we aim for 800. But once you give a dose of IVIG, you bump the level really high. And then you want to reach the desired trough, nowadays at least 800, in 3 to 4 weeks. Then when you give the next dose and go forward. Subcutaneous IG gets absorbed more slowly, and you have a lot more stable dosing. But because this is what's present all the time, you want it to be higher than the trough with IVIG. So I aim for about 1,000 after sub-Q IG, because that's also the highest level the patient's going to have, not just the lower. It's the level they have all the time. And finally, I'm going to describe some phenocopies of inborn errors of immunity. And here I'm going to talk to you about some the way to clear intracellular infections. And as an example, the mycobacterial infections. Normally when a macrophage takes up mycobacterial bacteria, it can't kill it right away, but that activates the production of a cytokine, IL-12. It's a signal that goes out to T cells or natural killer cells to make interferon gamma. Those cells make interferon gamma. The interferon gamma comes back to the macrophage, binds to its receptor, and then activates the macrophage to kill the mycobacteria. And defects all along this pathway can result in susceptibility to mycobacterial infections. There may be a problem in one of the proteins of the IL-12, could be a defect in the IL-12 receptor beta chain. It could be a defect in the interferon gamma chain or in the signaling molecules below, like STAT1. These defects here are sort of less severe because we can use interferon gamma as treatment, but if it's a defect in the response to interferon gamma, adding more interferon gamma will not help, and those patients are sort of have more serious infections with mycobacteria and will require probably a transplant for treatment. Now, a variety of immune deficiencies also are associated with bacterial infections, such as HIV and other T-cell immunodeficiencies. But people realized that some adult patients in Thailand and Taiwan had mycobacterial infections, but they did not have HIV. They did not have an inherited immune deficiencies. And when they studied them carefully, they noticed that they made autoantibodies against interferon gamma. And they found those in about 88% of those patients who had multiple opportunistic infections, especially mycobacteria. And it looked as if they had advanced HIV, but they didn't. And so here's an autoimmune disease that targets interferon gamma and looks exactly like a primary immune deficiency, but it's clearly a secondary immune deficiency. And more recently, with the COVID pandemic, there was a large consortium put together to study why some people had life-threatening COVID infections, and a large number of patients were asymptomatic or mild. And they studied these patients, and they found that about 3%, I think, of the life-threatening COVID infections had defects in the type 1 interferon pathway, genes that play a role in the type 1 interferon response. So when we get a viral infection, our cells in response to that will make type 1 interferons that help clear the viral infection. None of the patients with asymptomatic or mild COVID had any of these gene defects. Then they decided to look further and see if they had autoantibodies to type 1 interferons, similar to the mycobacterial disease and autoantibodies to interferon gamma. And they found actually a higher percentage, 10% of those with life-threatening COVID infection had autoantibodies to type 1 interferons. Again, none of the mild or asymptomatic infections. So here are two examples of autoantibodies targeting an immune pathway, if you like, that leads to susceptibility to infection. that looks like a primary immune deficiency, but it's actually a secondary immune deficiency. So in summary, primary immune deficiencies are rare inherited disorders. They present in early childhood, but they may also present later in life, like common variable immune deficiency. We clearly need a high index of suspicion to identify patients with primary immune deficiency, as well as secondary immune deficiency. Secondary immune deficiencies can result from a variety of external or internal factors, medications, biologics, immunosuppressants, viral infections, autoimmunity, protein loss. The treatment depends on the immune deficiency itself, but also on the underlying cause. So it's important to know what's causing the immune deficiency. Even amongst the primary, some gene defects can be treated differently. And secondly, for sure, you want to tailor therapy based on what the cause is. We now have a variety of options for treating immune deficiency diseases. Sorry, I should have taken out primary. The options for secondary are a little bit more limited, but again, depending on what it is, you may have to treat the underlying infection and replacing immunoglobulin, certainly with antibody deficiencies. But in others, you might need antimicrobial prophylaxis. Thank you, and I'm happy to take questions.
Thank you so much, Dr. Foulion, for such wonderful information, such an enlightening presentation. My bird is chirping at you. She enjoyed it quite a bit too. So thank you so much for providing that overview. We now have some time available for the Q&A. Before we begin, please remember that everyone's treatment and condition are unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. You should always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. So as I said, we received some pretty incredible questions. Let's get started with this one. Excuse me. We know there are genetic components to primary, but do we know of any genetic complications that make individuals more susceptible to secondary immunodeficiency?
So it's a very good question. I sort of hinted to that. Would you consider that secondary or not? So there are genetic predisposition to having autoimmunity, but if the autoimmunity targets the immune system, then you have a secondary immune deficiency resulting from a genetic susceptibility to autoimmunity. And amongst the patients who had autoantibodies to interferon, type 1 interferons, leading to a higher risk of COVID or COVID infections, more severe COVID infections. Some of them had underlying genetic conditions that would not have otherwise made them susceptible to the virus, except that they made those antibodies. So if they made the autoantibodies, they were more susceptible to COVID or to more severe COVID. So yes.
Very interesting. Thank you so much for clarifying. Next question. You mentioned that secondary immune deficiency is typically not treated with biologics. Are there any secondary immunodeficiencies that use plasma-based therapies like so many PIs typically do?
So, sorry, I may not have been clear here. Some of the biologics we use will cause the secondary immune deficiency.
Oh, okay.
In the rare case where the patient has autoantibodies to B cells or T cells, we may use a biologic to get rid of B cells, even though they have no B cells, but we want to get rid of this autoantibody production. Then maybe the non-autoimmune B cells will come back after that. And in the case of T cells, hopefully the T cells will come back after we use a biologic against the B cells. So I wouldn't rule out using a biologic for secondary immune deficiency, but in many cases, it's the biologic that caused the secondary immune deficiency.
Interesting. Thank you for clarifying. Can you explain a little bit more about the difference between conjugated and unconjugated vaccines? Is there anything about those vaccines that people with immune disorders should ask their doctors before receiving?
It's a very good question. So the whole idea of a conjugated vaccine was to protect young infants from initially Haemophilus influenza type B infections that cause really bad meningitis. And those kids under 2, for some reason, do not make good antibody to the unconjugated polysaccharide vaccines. It's probably just immaturity of the immune system that with time gets better. The only exception to older patients is those who have specific antibody deficiencies. They also don't respond well to the polysaccharide vaccines. So they added a protein because patients make good antibody response to tetanus and other proteins. So they conjugated the polysaccharide with a protein like tetanus or other proteins, and tricked the immune system. So the T cell that doesn't actually see the polysaccharide will see the protein and will help a B cell that's making an antibody to the polysaccharide, thinking that actually the B cell is making antibody to the protein, but it gets all the help that a protein response would have gotten, but makes an antibody to the polysaccharide. That's the conjugate vaccines. So because of that additional T cell help, they are more potent at inducing immunity. And now we have a variety. At first it was Prevnar 7, then Prevnar 13. Now there's a Prevnar 20, which kids don't get, but they do use for adults. The pneumonia vaccine was initially designed for adult patients because they are susceptible to pneumonia. It's called the pneumonia vaccine too. And so the conjugated vaccine many times is being used to immunize elderly as well, to give, and it's 20 instead of 23, but that covers most of them. The problem we have, if everybody uses the 20, then we have limited ability to test a response to a polysaccharide because it's all conjugated right now. But that's our problem as immunologists, not the patient. The patient, if they want the best immune response, they can get the conjugated vaccine. Also, the timing is important. If you give the traditional unconjugated vaccine first, it sort of suppresses the response to the conjugated vaccine for a period of time. In general, they would wait a year after the unconjugated vaccine to give a conjugated vaccine. So doctors prefer to give the conjugated vaccine first and then give the unconjugated to provide the best immunity. We use the unconjugated to test the immune system, not necessarily to provide immunity. So it's a different approach. But if you are an immunodeficiency patient and when you make the best antibody response, you would do the conjugate vaccine first, and maybe afterwards do the unconjugated just to get extra immunity as a result.
That is very interesting. Thank you so much for that explanation. Can you explain, I believe you spoke to this a little bit, but can you explain again what the indicator is for SCID in a newborn screening test if the baby already has maternal IgG?
Oh, so really great question. IgG is not, so the newborn screen test looks at the T cell receptor, and it's a DNA test that looks at the pieces of DNA that get formed when the T cells rearrange their receptors. And those also stay in that initial T cell, but as the T cell divide, those fragments, they're circles of DNA, they get diluted out. So if a baby has a lot of new T cells, they will have these T cell receptor excision circles and they'll show up on the newborn screen. And if they don't have, they're not making many T cells, that will be low. That's the, and the newborn screen just looks at low T cells. It'll pick up SCID, it'll pick up some of the George patients and other reasons for having low T cells. It's not a diagnostic test for severe combined immune deficiency. We then have to do confirmatory testing to see what the T cell counts are, see if the patients have enough naive T cells, which we can do, because any T cells that come from the mother will not have a lot of those T cell receptor excision circles. They will also be more memory than naive, whereas a baby should have a lot of naive T cells. And if the baby is male, it's easy to look for the X and Y chromosomes and tell that those cells are female or male. But I mentioned the gamma IgG being maternal in the first 6 months, because a lot of people initially look at immunoglobulin levels when they suspect immune deficiency, but in those 6 months, that may trick you to think that the baby is not immunodeficient, and you really should look at lymphocyte subsets as well in the first 6 months of life, because IgG may be normal, but it's coming from the mother, not necessarily from the baby. So, and that's different than the newborn screen. It's just when you're testing somebody in the first 6 months, be aware that the IgG is not the baby's IgG. So it doesn't tell you if the baby's able to make IgG or not.
That's really interesting. I never knew that the newborn screening wasn't actually a diagnostic tool. That's really interesting. Our next question, this individual asks, I have NK deficiency. Recent tests show a possible TFAT-5 defect. Is this considered primary immune disease? What can you share about this, please?
Yes, I don't know any examples of a secondary NK cell deficiency, although I'm sure there could be. But if you have an identified defect leading to NK deficiency, that's a primary immune deficiency. At the end, it's whether the NK cells function or not that's important. And of course, knowing the cause of it will help in many ways. If for natural killer cells, maybe not necessarily in the treatment, but at least would help genetic counseling, planning for children, and knowing sort of the risks. And so once you have a underlying genetic cause, but that would be considered a primary immune deficiency.
Very good. Thank you. We have a few more questions left, and we are running short on time. So let's try to power through a few of these real quick, if that's okay. This individual asks, I have CVID. Should I have a gene panel done, and what tests should I have?
It's a great question. Yeah. And I don't know that there's a straight answer. Getting a genetic test is a personal choice. Because you might learn some other things that you were not intending to learn, especially when you do a panel of, now it's at least 400 and some genes that you're looking at. So you might find some things that you weren't looking for initially. Where I would say that you really should do a genetic test is if the CVID is complicated. Is there autoimmune disease? Are there GI complications? Some genetic causes of CVID have other therapies than just immunoglobulin that might help this autoimmunity or inflammation that's ongoing, and that would be worthwhile knowing.
Very good. Thank you. This individual asks, is poor diet / bulimia / anorexia also considered to be a secondary immune deficiency?
Very good question. I didn't bring that up. Certainly malnutrition can affect the immune system too, and would be a secondary immune deficiency.
Very interesting. Okay, next question. Recently, a number of adult patients have been diagnosed with SCID, but are not necessarily given a genetic diagnosis. Do you think that the majority of these are some type of leaky SCID, or more likely secondary?
That's a very good question. Although I do take care of adult patients, I'm mostly focused on pediatric. I think that's the easiest answer would be that it's leaky, but it's probably more likely combined immune deficiency rather than the classic severe combined immune deficiency. So I need to know more to be able to answer more definitively.
Okay, thank you very much. Next question, are granulomas something that every CVID patient will at some point have?
No, I think it was only about, 10% if we looked at that table. So it's a subgroup of CVID. If we could identify, which subgroups are more at risk, would obviously be very helpful. Again, the more genetic testing we do, the closer we will get to making these, but it may not be total. It may not be one of the genes we know of right now that's responsible for this, and it could be more an issue of like inheriting a second gene defect, not just one. So it's maybe more complicated, but I think the granulomas were in about around 10% of patients or so. So definitely not every patient.
Okay. Can you please speak about mannose binding lectin deficiency? Do you have any information on that to provide?
Well, that's a very controversial. It does play a role in the complement pathway. The lectin pathway of complement, I didn't mention it. most immunologists feel that it doesn't cause a significant immune deficiency because there are other ways to handle the infections. And some feel that maybe totally absent MPL can be associated with recurrent sinusitis. Unfortunately, there's no specific therapy for it except prevention with as good drainage of the sinuses as possible, and maybe preventative antibiotics depending on the frequency and severity of the sinusitis.
Thank you so much. 2 more quick questions. Does everyone have auto antibodies present? And if they do, at what point would it be definitive of an autoimmune disease?
So in general, when you look for some types of autoantibodies, you would find them being absent in most people. So, but the question, does everybody have autoantibodies? We don't test all antibodies, and so many of us might have, but having any antibody, whether it's auto or otherwise, even IgE that causes allergy, that doesn't necessarily mean you have that antibody is actually causing disease. So you need a manifestation of the disease. You need to have hypothyroidism, low platelets, something that gets associated with autoantibodies to have an autoimmune disease. If you want to take it, maybe in the simplest form, is having an IgE antibody, let's say, to a food. Many patients have them, but they can eat the food. They don't have allergic disease. What makes them then have the disease, or what's the difference between those who have it and those who don't, is still not clear, and it's something we need to learn, but also a fascinating aspect of immunity. Just having an antibody doesn't mean you have a disease from that antibody. It has to be doing something to cause the disease.
Very, very interesting. All good questions and all good answers. Thank you so much, Dr. Foulion. And with that, the Q&A and our time together in this session has come to an end. So again, thank you, Dr. Foulion, for providing such wonderful insight. It has been an honor to have you join us today. And as a reminder to those watching, this session is one of 39 unique learning opportunities provided through our 2023 PI conference. We hope you continue tuning in today as we explore other critical topics for the PI community. Thank you all so much, and have a wonderful, wonderful rest of your day and weekend. Bye-bye.
Thank you. Bye.